Are we good now?
Yes, please go ahead, Kashif.
All
Thank you.
all right. So today my topic of discussion is laryngopharyngeal reflux and the Lewin consensus. Uh, it's stuck. Stuck. All right. So my disclaimer is that I'm in fact a student of this subject. So I'm not an expert, and I would like to be corrected if there is any mistake. I would like to be rectified. And the learning objectives of today's discussion are understand LPR and distinguish it from its mimics. And the second part is to understand the Lewin consensus and the pharyngeal and the upper esophageal sphincter motor disorder. Application of Lewin consensus for diagnosing pharyngeal and upper esophageal sphincter motor disorder. So the first part is laryngopharyngeal reflex. So this is a case scenario. A 45-year-old female, chronic hoarseness of voice for the last 6 months, complaining of frequent throat clearing and globus sensation. She denies any history of heartburn. Her laryngoscopy showed posterior commissure hypertrophy, and her reflux symptom index is 18, and reflux sign assessment score is 8. So, what will be the next best step in the management of this patient? So the laryngopharyngeal reflex, the definition, there are several definitions for this. The top one is from the American Academy of Otolaryngology, head and neck surgery, that was first defined in 2002 and then revised in 2024. So this one is, they define in 2024 as the backflow of gastric contents into the throat, that is the laryngopharynx. And another one is the Montreal definition, and they defined LPR as extraesophageal syndrome of GERD. While GERD is primarily an esophageal disorder with extraesophageal complication, they have defined LPR as extraesophageal syndrome of GERD. Another definition that is, I got it from a study by Hand et al. In 2023, and they defined it as a variant of GERD in which gastric reflux that irritates the lining of the aerodigestive tract and causing airway symptoms or complications. So, regarding the epidemiology of LPR, there were no population-based studies. These information that I got from small-size studies, and the diagnosis was based mainly on clinical features. So in UK, taking the reflux symptom index more than 10, in that study out of 951 participants, the prevalence was of LPR was 26.5. In USD, approximate prevalence is 1 out of 10 adults. And in Malaysia, there was a hospital-based study by Ishak et al. In 2021, and they performed the study on hospital staff, and the prevalence of LPR was 20.3%. And remember that these studies were performed based on the clinical features. Other countries have reported prevalence of approximately 31.2%, and this entity is most common in 4th to 5th decade of life and more common in female. So regarding the pathophysiology of LPR, there are three main components of it. That is the lower esophageal and upper esophageal sphincter incompetence. The second one is the weak or slow peristaltic wave that is insufficient to clear the contents from the esophagus. And the third one is the pepsin and acid-mediated injury of the aerodigestive tract. So regarding the clinical features, there is no pathognomonic symptom or sign. Multiple studies have performed to find or to look for the pathognomonic sign. However, each of these came with their own frequencies are the most common presentation. There was one study that I took was Masavi et al. In 2021. That study is published in BMC Gastroenterology, and they found that globus was the most common symptom of LPR, followed by hoarseness and throat clearing. With respect to signs, the most common was thick endolaryngeal mucus, vocal cord edema, and partial ventricular obstruction. And apart from that, they found that lying down within 2 hours after taking meal was the most common risk factor for developing these symptoms. So the diagnosis is not that straightforward. So you have to look at the bird eye view rather than relying on simple or single entity. So a diagnosis should be made based on clinical plus reflux symptom plus endoscopy and response to treatment. So a combination of all of these should be, and more importantly, you have always exclude the mimics while labeling a patient with LPR. We will discuss later the mimics of the LPR. So regarding the clinical, based on symptomatology, there is a score that has been developed for this. The score includes, which is called the Reflux Symptom Index. So it is basically a questionnaire that is handed over to the patient, or the physician can just ask. And the symptoms are basically asked that are experienced by the patient in the previous month. And it includes 9 symptoms, including hoarseness, frequent throat clearing, postnasal drip, difficulty swallowing, coughing. So all of these, none of these is a pathognomonic. These are very non-specific symptomatology. The total score is 45, and there is no specific cutoff in this score to diagnose LPR. However, there was a study in 2024 that when took the score 13 as cutoff for LPR, the sensitivity was 97.1% and specificity was 66.7%. So the sensitivity is good, but specificity is quite low, that is 66.7% of the score. The second thing in clinical is the objective assessment. So objective assessment is based on laryngoscopy findings, and there are a lot of clinical findings. Again, none of these is pathognomonic or specific for LPR. However, the score they have developed based on these findings is called reflux sign assessment. The total score is 72. And again, there is no specific cutoff. However, in a study in 2025, when taking the 38 score 38 is cutoff, the sensitivity was 90.3%, specificity was 85.0%. So it was a single study that needs further, validation to confirm this finding. So there are some novel tests that are still under developing phase. Among these is the salivary markers. So these are the salivary markers. Among these is the PEP test. This is a novel test. Again, it is in developing phase and validation phase. So what it does is it detects pepsin in saliva, as we discussed in pathophysiology, that it is pepsin and acid-based injury of the aerodigestive tract. So what this test does is it detects saliva, pepsin in saliva. The cutoff is taken as 25 nanogram per ml. The pool sensitivity in one meta-analysis was 64% and pool specificity was 68%. So again, but the test is again alone, it is not diagnostic for LPR. However, one study reported that it is a good test in measuring the response to treatment. Another saliva-based test is SEPT70 test, which detects squamous epithelial stress protein 70, which it is basically present in the upper aerodigestive tract, and it is basically a mucosal protein that protects the hypopharynx. And when its lower level is suggestive of LPR, it is still in developing phase and not commercially available. The next under trial test is salivary bile. So the third is the role of endoscopy in LPR. There is no direct role of endoscopy in LPR other than to rule out the esophagitis, and the second one is the globus sensation. So in case of globus sensation, we have to rule out to look for a gastric inlet patch in proximal esophagus. The fourth one is the ambulatory pH monitoring. So pH can be measured with wireless pH capsule, which has no role in diagnosis of LPR. And I'll be talking about most of the time the most diagnostic, in fact, the gold standard for LPR, which is the 24-hour hypopharyngeal multi-channel intraluminal impedance pH monitoring, which is the recommended, in fact, the gold standard for LPR. So this test, it distinguishes the acid versus non-acid reflux and incorporates two upper esophageal sphincter sensors. Again, as I said, considered as diagnosed gold standard for LPR. In the reflux set, or what it the reflux set in the hypopharynx, it is said that the pH drops in the weakly acidic portion, that is 4 to 7, is suggestive of LPR. However, the problem with this test is there is no consensus about the number of reflux episodes that label or diagnose LPR. So this is one of the limitation. There is no consensus about this. In one study, the author reported that if we consider more than one pharyngeal reflux episode, the sensitivity of this for LPR will be 76% and specificity will be 81.5%. Another is the novel test is the MyVu, which the role of MyVu in direct role of MyVu in LPR is still limited. However, it can differentiate GERD, non-acid reflux, and eosinophilic esophagitis. So the differentials are the mimics of LPR. Among these, the most important is GERD, which I have drawn this table to compare GERD. The primary feature, again, these are not pathognomonic, but however, we can just by a look at it, we can differentiate between the two. The primary symptom injured is heartburn, in LPR hoarseness, globus, and the reflux rate injured is mostly acidic, while in LPR is acidic plus pepsin. Again, there is the position that GERD is most common, mostly occur in supine as compared to LPR, which occurs in upright position. And there is no esophageal or minimal esophageal injury in LPR, and while the GERD gives good response to PPIs. Other mimics include chronic rhinosinusitis, allergic rhinitis, and tobacco-induced laryngopharyngitis. So the treatment, coming to the treatment of LPR, the treatment of LPR includes multimodal approach, which means it to include dietary and lifestyle changes, the medication, and I'll be talking about the application of endoscopy and surgery in LPR. So dietary and lifestyle modification includes the avoidance and the recommendation of certain food that should be avoided in this condition, and certain which should be encouraged in this. So the food that should be avoided includes those which increase the intragastric pressure, like the high fat, and those which reduces the LES pressure, for example, alcohol. And the recommended food include high proteins and alkaline diet. Weight loss is, though it is advised to in LPR, but it's not directly assessed. Rather, its role is advised based on its role in GERD. So the coming to the role of PPIs and the acid separation in LPR, the PPIs are often described in LPR. However, it is a subject of debate, and there are conflicting views about its role in LPR. But in LPR with esophageal symptoms, PPIs are always recommended. In one study, the author recommended that all patient of LPR should receive trial of PPIs for 8 to 12 weeks. This trial has both diagnostic and therapeutic effect. So apart from PPIs, some topically acting protectives like the alginates, they are also recommended, and they protect the mucosa from the effect of the pepsin. In one trial, it was a three-arm trial. The alginates were found non-inferior to PPIs, and they were found non-superior to placebo. So the next in the management is baclofen, which is GABA B agonist, and it has no direct role in LPR. However, its role was in fact extrapolated from its role in GERD. Though, so they may be advised, but as an add-on therapy, not isolated. And the next is the role of neuromodulators. So neuromodulators include those which reduces the symptoms, for example, the chronic cough. There is a study in which pregabalin and amitriptyline were found with some success. However, the role still further required further research. Now, the more important is the speech therapy, which is recommended for all patients, and it reduces the laryngeal symptoms. In one study, the medication plus the speech therapy was found to be more effective in treating LPR as compared to medication alone. So the endoscopic and surgical intervention, as I said earlier, that role of there is no direct role of endoscopy. However, it may help in ruling out its mimics, for example, gastric inlet patch. So endoscopy can help in ablation of if there is a gastric inlet patch. Surgery is indicated in LPR when there is PH studies proven GERD symptoms. Which surgical type? That is the fundoplication. In one study, as is mentioned there, the reduction of the improvement was observed with fundoplication in 80% patient, and that led to discontinuation of PPIs. Other novel devices, which is called the upper esophageal sphincter assisted device. So it is a device that is actually applied on the cricoid. And what this device does, it applies a pressure of 20 to 30 millimeter on the cricoid and prevents the reflux. So it is still under trial phase. One pilot study with the 15 patient showed complete response in 29% and partial response in 58% patient. However, the response to treatment was based on the 50% reduction of the symptoms. So how to measure the response to treatment? So it can be measured based on clinical scores such as the reflux symptom index or the reflux sign assessment, and objective testing like the pH studies. Uh, it is recommended that rather than stopping it abruptly, the treatment should be stopped in a step down manner. So coming back to the case study, the 45-year female, chronic hoarseness for 6 months, frequent throat clearing and globus. She denies any heartburn, laryngoscopy, short RFS, RAS, reflux sign assessment of 8 and reflux symptom index 18. Next best step will be 24-hour ambulatory hypopharyngeal multi-channel impedance pH test. So that concludes the first part of the presentation. Now we will be going toward the second part, which is the Lewin consensus. So this is the Tower of Babel, which is it is a Greek mythology, and it is a tower. The story about this tower is that in the biblical era, the people were very intelligent, and they were building a tower to reach the sky. So the goddess, as per their story, the goddess became very angry with this thought, and what the goddess did is the goddess confounded their speech, so they were unable to communicate to each other efficiently. Resultantly, they couldn't complete the tower. So, correlating the tower story with the Lewin consensus, before the Lewin consensus, there was no unified language or speech regarding the pharyngeal and upper esophageal sphincter motor disorder based on manometry findings. So the first time this paper was released in 2025, that unified the language of pharyngeal and US motor disorder, giving a short overview of the muscles of contraction, so muscles of swallowing, so in the pharynx. So the includes three constrictor muscle, that is superior, middle, and the inferior. And the lowermost part of the inferior pharyngeal is called, which is a specialized band, which is called the cricopharyngeus, which forms the one of the component of the upper esophageal sphincter. The upper esophageal sphincter is a complex system. The cricopharyngeus alone does not define it, rather it includes other cartilages and other parts as well. However, it is very important, one of the most important part of the upper esophageal sphincter. And the three longitudinal, that is stylo-palato and salpingopharyngeus. So the indications and contraindication for pharyngeal HRM with impedance. Indication include upper esophageal sphincter dysfunction on face, fiber optic evaluation of swallow. Uh, the next is the video fluoroscopic swallow study. If there is any US dysfunction on these tests, so we proceed for the HRM studies. And then to objectively quantify the propulsive and restrictive forces of the swallow. And the third is the response to treatment in following interventions like the myotomy for Zenker diverticulum, or in case of cricopharyngeal spasm following Botox injection. Contraindication include nasal obstruction, trauma to the skull base, risk of bleeding, or trauma to the nasal cavity. So the metrics of the pharyngeal esophageal manometry. So there are two parts. One is the upper esophageal sphincter, and the second one is the pharyngeal part. So consider it like a pump and a valve, with the US, the upper esophageal sphincter, working like a valve, and the pharyngeal part that is working like a pump. So that's how I, kind of simplified this for myself to understand it, that the upper esophageal sphincter that works like a fell kind of restrictive force, and the pharyngeal contractile force kind of propulsive force like a pump. So these are the going back. Sorry, the valve include four parameters or metrics, including the hypopharyngeal intrabolus pressure, the integrated pressure of the US, just like the lower esophageal sphincter in esophageal manometry. The third one is the maximum admittance and relaxation times. So admittance is can say it's like a cross-sectional area that of the US to allow the bolus to pass, and relaxation time is the time for which the US remains relaxed. And the parameters of the pharyngeal, the pump, these mainly include the contractile force, the strength, the vigor of the muscles to push the bolus down into the esophagus. So these are the various metrics, with their normal values, and these are not the actual definitions. Actual definitions are available in the paper, the Lewin consensus. I have just mentioned what they represent. So this is looking at this picture. The first right on the left, the first graph on the left, top on the top left, that is an old line manometry graph, which was previously performed, and the second one is the topography plot, that is the newer or the high resolution manometry. The third one is the third one includes the impedance. So these are the plots that are obtained based on the uh, HRM findings. So as you can see, the plot is divided based on the cavities, the pharyngeal cavities. So the first one is the velopharynx. Nasopharynx, as it has no role in swallowing, so it is not taken. And this one is the velopharynx, the upper one, mesopharynx behind the base of the tongue, and below that is the pharyngeal, the hypopharynx. And this one is the UES, that is the upper esophageal sphincter. So when a bolus is coming over here, it relaxes, and these are the actually the red hot spots. These are the strength or the contractile force of the pharyngeal muscles. So the Lewin consensus unified the technique of the pharyngeal and upper esophageal function, and they not only defined the how to diagnose, but rather they also define how to assess the pharyngeal and the how to perform the pharyngeal manometry, pharyngeal and upper esophageal sphincter manometry. So it is performed by offering a challenge test to the patient, which include the 5 ml, 10 ml liquids, and the volume is further increased to 20 ml. So not only the volume is assessed, it also assesses the viscosity. The viscosity is changed, and the the challenge is offered to the patient are the 5 ml viscous and the 10 ml viscous. So as you can see, the number of swallows they are much less in number compared to the esophageal, because these muscles, these are skeletal muscle as compared to the smooth muscle of the esophagus. So these number of swallows, these number of swallows are enough to understand what is going on. So how to uh, diagnose the upper esophageal sphincter dysfunction in this? As we said previously, going back to the previous, the 5 ml liquids, these are mostly tolerated by most of the patient. In fact, one can ask the patient the how much fluid, how much you can tolerate. So the patient will tell the amount of fluid that he or she can tolerate. The 5 ml liquid is mostly tolerated by most of the patient. So to label the upper esophageal sphincter, one has it is diagnosed based on the majority of the swallows of the 10 ml swallows. As I said, the 5 ml are mostly tolerated. So while labeling the UES dysfunction, it is started from 10 ml swallows. If a patient is unable to swallow 2 or 3 out of the 10 ml swallows, going back to the previous slide, this one, there are 3 swallows of the 10 ml. So 2 out of these are the patient is unable to tolerate with 2 or more abnormal UES metrics. As I said previously, the metrics of the UES include the intrabolus pressure, IRP, maximum admittance, and relaxation times. So when 2 or more of these are abnormal, in 2 or more of the 10 ml swallows, the upper esophageal sphincter dysfunction is labeled. If other than that condition, that is considered inconclusive for UES dysfunction. So here are some examples. This one is a case of 45-year female with post-radiotherapy cervical web. The other one is cricopharyngeal bar. So as I said previously, this is a 10 ml challenge. The 10 ml challenge, and you can see that out of these 4 metrics, 3 are abnormal. Similarly, in the 20 ml challenge, 3 are abnormal. So as we said previously, there are two or three, and these are two out of three swallows. These are abnormal, so a diagnosis of US dysfunction is labeled. Similarly, in this case, that two out of three are abnormal, and the this one two out of three, and this one is three out of three. That one is abnormal, so a diagnosis of US dysfunction is labeled. The next part is so we discussed the US, as we said that there could be a dysfunction in the valve, or there could be a dysfunction of the pump, like the pharyngeal contractile dysfunction. The pump may be either not performing well, or it could be performing above its capacity. So if it is performing, as we said previously, that there are three components of the on HRM, that is the velo, meso, and hypopharyngeal. So if all of these three are performing, are underperforming, that is, they are unable to push the bolus. The diagnosis of pan-hypopharyngeal contractility is labeled. When all the three components of the pharynx, they are unable to push the bolus, the diagnosis of global pharyngeal hypocontractility is labeled. If some of the components are hypocontractile, they are unable to push the bolus, then fragmented pharyngeal hypocontractility is labeled. So if these were the condition when there was the pump was not performing properly. What if there is the pump is performing above its function, above its capacity? So the hyper, that is called the pharyngeal hypercontractility. But whenever there is a pharyngeal hypercontractility, always look for a UES dysfunction, because there is a well that is not performing properly and the pump is trying to push against an incompetent or a hypercontractile or an incompetent well. So the pump is trying to push against it. To overcome that, the pump tries to increase its capacity. So always look for a UES dysfunction in the case of hypercontractility. So these are some examples of pharyngeal, the pump failure. There, this one is normal. As you can see by comparing with this, the velo, meso, and hypopharyngeal, all of these are hypocontractile. So when all the components are hypocontractile or low absent contractility, that is labeled as global pharyngeal hypocontractility. And when some of the components like this one, these are either absent contractility or either low contractility, that is labeled fragmented pharyngeal hypocontractility. And when this one, as you can see, the red hot spot in all the three components, so it is a hypercontractility. And always look for the upper esophageal sphincter dysfunction in case of hypercontractility. So the key takeaways of this discussion: LPR, there are no specific sign and symptoms. The reflux symptom and sign assessment score are inaccurate. Hemi-PH is gold standard. Always exclude mimics while labeling patient with LPR. Treatment includes multimodal diet, lifestyle, acid separation, and speech therapy. Lewin consensus classifies pharyngeal unified, the language of pharyngeal and upper esophageal sphincter motor disorder, and important for dysphagia evaluation, pre-surgical assessment, guiding swallowing therapy, and post-intervention assessment. These are the references. Thank you.
Great. Thank you, Kashif. I think this is very well delivered. I would say that you have really read through it thoroughly and summarized it very nicely.
Thank you. Thank you.
Great. I'm not sure if there's any questions, but I don't know, Joash, do you have any question for Kashif?
None for me. I thought I agree, Prof. It was a very good session and it was a very good summary of a very difficult topic. Maybe just one thing is that, Prof, I think we, in our practice, instead of 5-10, we go straight from 5 to 15, and there was a reason, Prof, based on the data that we have collected earlier on, is that our 10 ml, we found that there was no significant difference between our 5 mils and our 10 mils UES swallows. That's why I think we modified to 5 mils and 15 mils. Just to add that part only.
Yes, I mean, the data that we have done are obviously before Leuven. And I agree with you that the data that we collected did not show any difference. Now that we have a Leuven, we can come back to our drawing board and see how we can incorporate what we learned today. Yep. And just to reiterate that we did also have some data on RSI and also the reflux finding score, or what Kashif mentioned as the reflux sign assessment. So if just say, I'll probably try to share the data if you can remind me. In fact, that paper hasn't been written out. We wanted to write it up, and maybe you can talk to Dr. Fariza, because she is the lead investigator for this particular study that we have did quite a while ago. Yep. So in that case, if there are no other questions, we will definitely post this up in the YouTube. And if there's any comments, yeah, please put that in the YouTube. And also, if you have any other questions coming from us, we will also direct to Kashif. Unless, are there anyone else who wanted to ask any other questions? If not, then I'll thank you very much, everyone, for attending. And yeah, thank you,
Thank you.
Kashif, again for the excellent lecture.
Thank you, Prof. Thank you.
Thank you very much.